Well, hello, and good morning, good afternoon, and good evening to everyone who is joining us today. My name is Bethany Young Holt, and I am the director of the Initiative for Multipurpose Prevention Technologies, or the IMPT. And we are a project of CAMI Health, which is housed at the Public Health Institute. And I'm joined today with my colleagues, Madison Langren and Vera Zhang, who are going to be here to provide tech support. I am really delighted that the IMPT is hosting this webinar today as part of our Let's Talk MPT series, which is sponsored by the Eunice Kennedy Shriver Institute for Child Health and Human Development, or NICHD. This webinar series was launched over 2 years ago to engage experts from diverse disciplines across the globe to help address MPT R&D priorities and gaps and ensure that the most promising candidates reach end users. So as rates of sexually transmitted infections continue to rise globally, and these infections are interlinked with risk of HIV, unintended pregnancies, I'm really excited about today's webinar on STDs, public health status and opportunities for MPTs. So we have over 100 people registered from across the globe and time zones joining us today. So as we wait for others to be let in, I'd like to invite you all to type your name and affiliation and where you're located in the chat feature. So I think, yeah, so we also want to note that everyone will be muted during the presentations and that you can unmute yourselves during the question and answer. If you have any questions for our speakers during their presentations, please use the chat feature and we'll address them in the question and answer. And then for technical issues, you can just chat Madison, who is one of our tech hosts. The webinar recording and related resources will be available on the IMPT website soon after the webinar. And so today's webinar, we're going to be hearing about current trends in STIs globally, as well as challenges and opportunities for MPTs that can help with STI prevention efforts, including HIV. So we have a terrific lineup of speakers with us today with expertise in areas of STIs, MPTs, and drug development. And we will also have a facilitated discussion. And as in the past, we're really looking forward to an engaging discussion. So, as I mentioned, this webinar is hosted by the Initiative for MPTs, or the IMPT. The IMPT was launched in 2009 as a product-neutral body to foster an enabling environment for successful MPTs. And just to remind everyone, MPTs are products designed to combine the prevention of 2 or more health risks, unintended pregnancy, HIV, or other STIs into a single product. So this MPT development is complex and it involves multiple research disciplines, including traditionally siloed fields of HIV, STIs, and unintended pregnancies. Next slide. So since the launching of the IMPT, we have been tracking the pipeline in an online database, and over the last decade, support for MPTs has grown. Currently, condoms are still the only MPT available, but an array of new MPTs have entered the development process, and they represent diverse delivery approaches and targeted audiences. The majority are in early stages of preclinical or clinical development and are primarily focused on combining anti-HIV drugs with hormonal contraceptives into single products. As of December of this past year, there are 28 products in the pipeline. If you're aware of any more products that are not listed in the database, you can let us know. So as with past webinars, as I mentioned, this webinar will be posted on our website in our MPT Learning Events Resources page, and you can also check out some of the other resources that we have available, including the Regulatory Resource Hub. And we again welcome other resources that you all have, and we share those. So next slide. So, as I said, we have this terrific lineup of speakers today. Our first speaker is Dr. Ina Park, who is professor of medicine in the Department of Family and Community Medicine at UC San Francisco. She serves as the medical director as well for the California Prevention Training Center. She serves as a medical consultant to the CDC, Division of STD Prevention, and recently co-authored the 2021 CDC STI treatment guidelines. Dr. Park also has served as a committee member for the HHS First Federal STI Action Plan and is serving a 2-year term with Planned Parenthood. Dr. Park is also the author of a book called Strange Bedfellows: Adventures in the Science, History, and Surprising Secrets of STDs. I must say this is an extremely fascinating and witty book. And if you've not read it, I'd highly recommend it. Our next speaker is Dr. James Cummins, who I'm sure many of you know as the chief of the preclinical microbicide prevention research and prevention sciences program within the Division of AIDS at the National Institute of Allergy and Infectious Disease at NIH. Dr. Cummins leads a team that manages a portfolio of grants and contracts supporting preclinical development of non-vaccine biomedical HIV prevention products. His active grants, or the active grants in the program, support the development of the next generation of HIV prevention products, including sustained release long-acting products and MPTs. There are a variety of funding mechanisms available, and these have supported the development of a range of formulation types and facilitated the advancement of at least 12 products into NIAID-sponsored clinical trials. And our third speaker and also co-moderator during the discussion section is Dr. Kathy Yang. She is the co-vice dean of clinical intervention, innovation, and entrepreneurship, and a health sciences clinical professor in the Department of Clinical Pharmacy at University of California, UCSF. And Dr. Yang specializes in the treatment of multi-drug resistant infections, particularly gram-negative bacteria. Her area of research focuses on pharmacodynamic optimization and antibiotic dosing. So with that, I am going to hand it over to Ina.
Thank you, Bethany. Next slide. Again, I'm Ina Park. I'm going to talk about some epidemiology as well as STI syndemics with other conditions and other infectious diseases, and then antibiotic resistance. And then I promise it's not a total downer. We'll have a little bit of good news at the end. Next slide. So I'm going to start with some global epidemiology, and I think I can convince you in 2 slides that STIs are everywhere. So more than 1 million sexually transmitted infections are acquired every day worldwide, and the majority of which are asymptomatic. Just because the STI is asymptomatic certainly can still cause havoc. There's about 374 million new infections with the curable STIs, which we think of as chlamydia, gonorrhea, syphilis, and trichomoniasis. And these are statistics, by the way, from the World Health Organization. And then, of course, almost 1 million pregnant women were estimated to be infected with syphilis. And the data from WHO are actually from 2016, so they're quite old, resulting in a large number of adverse birth outcomes. And as folks on this call well know, those can include stillbirth and neonatal death in the first 30 days of life, as well as long-term neurologic and physical disability. Next slide. So I want to touch also on HIV, which, is a viral STI after all, right? The global prevalence of HIV has been pretty level actually for the past 20 years. And the latest data from UNAIDS are from 2021. So the global prevalence was about 0.7%. And obviously there are populations that are more heavily affected. That equates, though, to about 38.4 million people living with HIV in 2021. And 1.5 million incident or new HIV infections in 2021. So now transitioning back over to what we think of as more traditional STIs, there's more than 500 million people 15 to 49 years of age who have a genital infection with HSV or herpes simplex virus. So it's pretty staggering, actually. You know, we think of the HIV numbers being pretty impressive, but herpes and other viruses such as HPV, HPV is, you know, we don't have statistics, it's pretty much universal, is associated still with 311,000 cervical cancer deaths each year. And again, these are old data from WHO. And we will say, though, that in our world, HPV is a wonderful virus to work on because we have an effective vaccine. And in the United States, that vaccine happens to be non-valent. And in other places, they have even higher valency vaccines, as well as some folks still using the bivalent vaccine. Next slide. So I just want to spend a little bit of time talking about syndemics because I think many people on this call understand that the populations that might have a very high prevalence of, you know, HIV might also have a high prevalence of STI because, you know, some of the risk factors overlap, some of the sexual networks overlap. And so just to give you an example, we could do this for many conditions. You know, this could overlap as well, for example, with poverty or systemic racism or mass incarceration. So, you know, these are not necessarily the end all be all in terms of the syndemics that can affect STI. But I just wanted to point out that on the left, you know, I wanted to say that there is certainly sort of overlap Venn diagrams with STI, HIV, substance use, and hepatitis C, for example. And then on the right here, particularly for folks who can become pregnant, there's an overlap between HIV, STI, and unplanned pregnancy because the behaviors that lead to one can lead to the others. So the other thing I wanted to say is that for now, for the next few slides, I just want to focus for the audience on the interplay between HIV and STIs. Because understanding that we have a syndemic sort of approach to thinking about these infections means that, you know, things like MPTs, which may potentially prevent multiple conditions at the same time, are just really, you know, key and important, understanding the fact that, you know, we are not looking at infections in a sort of isolated way. Next slide. So I'm going to start off with trichomonas and HIV acquisition in women. And so this is just a meta-analysis. I'm going to be showing you lots of forest plots from meta-analyses, but you don't have to read all the fine print. I will sort of summarize all of them for you just to say in 2018, Masha et al. Published this meta-analysis of 11 studies. And so the hazard ratio of HIV acquisition for folks who had trichomonas was about 1.5 times compared to you know, women without trichomonas. And so I will also say that when we look at these meta-analyses that show an association, I can't necessarily tell you certainly that one causes the other. And we can think of biological reasons why having an STI and increased inflammation, you know, might lead to a higher risk of HIV acquisition. But I just want to point out that these are studies of association. And so, you know, they're not necessarily studies of causality, but we certainly think that that they are tightly linked. Next slide. In terms of the relationship between syphilis and HIV acquisition, certainly I think many folks know that the syphilis epidemic in many countries is focused in men who have sex with men, but certainly women and other folks that can become pregnant are highly affected. And the interplay here with HIV acquisition, 17 studies just published actually a few months ago by Barker et al. In STD, with a hazard ratio for HIV acquisition of almost 1.7 based on 17 studies in a meta-analysis here. Next slide. I'm just going to pick on gonorrhea, not because they actually have meta-analyses here for trichomonas and chlamydia that I'm not going to show in this study by Barker, but gonorrhea was associated with HIV acquisition with a hazard ratio of 2.8 based on about 16 studies. Next slide. And then I can't even show the entire forest plot for all of the studies that have looked at the relationship between herpes simplex virus and HIV acquisition. And remember, for folks who have symptomatic herpes infection, who actually have recognized sort of lesions, that you're actually going to have a genital ulcer, which is a prime entry point, for example, for HIV into the bloodstream. This is based on 39 studies with 55 different point estimates. So for folks who are already living with HSV, the hazard ratio is about 1.7 based on 39 studies. And for those with a incident HSV infection, and usually, if someone gets an outbreak, those outbreaks are more severe, the hazard ratio is almost 3. And this was published by Looker et al. in The Lancet Infectious Disease. So because I'm based in the US, I also wanted to share with folks what is happening in the US in case you weren't aware. Next slide. So these are based on 2018 estimates and were published in 2021 by CDC, but I'll tell you that, based on WHO statistics and US statistics, the pattern sort of what the most common STIs are is pretty similar. So HPV sort of being the king here, almost universal again, and then HSV2 following behind. Then, of course, trichomoniasis, and then other STIs, with HIV sort of being closer to the bottom, and syphilis actually being the least common sort of the sexually transmitted infections. But just to point out, you can look at the sort of pattern of prevalence in purple here and incidence in blue. And for a condition such as trichomoniasis that I want to point out, where you can easily cure trichomoniasis with a course of antibiotics, you'll see that there'd be a much higher incidence than actual prevalence of folks living with the infection, where as the opposite would be true for herpes, which is right above on this slide. Because herpes is a lifelong infection, then the prevalence of folks living with HSV once infected is going to be higher than the incident infections per year. But just the numbers, it's hard to envision what this means in terms of how common these are, but as an example, with HSV2 at its peak in 2007, 1 in 4 Americans were estimated to have antibodies to HSV2, and now we're getting closer, to 1 in 8 and to 1 in 8 to 1 in 12, depending on the population you're looking at. So it's going down, but again, very, very common. Next slide. And these are the preliminary data from 2021 that CDC has put out to say that other than chlamydia, which did see a decline during the pandemic and hasn't really caught up because asymptomatic screening hadn't caught up to its pre-pandemic levels. Other than chlamydia, all the other STIs for which we do surveillance, and in this case, we're talking here about gonorrhea, syphilis, and congenital syphilis, all went up. Gonorrhea has had a 25% increase in the past 5 years. Syphilis has had a 68% increase. And I think the most staggering of these is congenital syphilis, with a 185% increase in the past 5 years. And I want to mention, out of these 2,600 babies who were classified as having congenital syphilis, there are over 200 stillbirths and neonatal deaths in the first 30 days of life by a condition, as we know, which is completely preventable with penicillin therapy, which is very inexpensive. Next slide. And I know this isn't, exactly relevant to, MPT products, but I just wanted to set the stage by letting folks know what is happening with syphilis among women of reproductive age. And just to show you that the congenital syphilis cases in blue and the cases of syphilis in women in the black bar are obviously tracking side by side. And next slide. Because we talked about syndemics, I also want to point out that syphilis in reproductive age women and in babies is, certainly a syndemic with substance use. And I just wanted to point out that over 30% of folks who had a syphilis case, these are among women of reproductive age, had sex while intoxicated or high, or had sex with anonymous partners. And here in California, where I sit, a third of the cases of primary and secondary syphilis among women of reproductive age report use of crystal methamphetamine. So my point is that, none of these is happening in isolation, and just wanted to point out an example of this endemic here with substance use in the US. Next slide. And as I pointed out, I sort of scooped myself, just wanted to point out that, again, about a third of the cases used crystal meth, but you'll see that actually that's been going down in the West and the Midwest and in the South, but is increasing in the Northeast. Next slide. And along the lines of, the downer portion of my talk, I just wanted to say that antibiotic resistance is a huge threat in the US as well as worldwide. And the US government and CDC put out a report about antibiotic resistance threats. And I don't know if I'm proud or disappointed to say that 2 STIs made the list. Next slide. Gonorrhea made the sort of urgent threat list, primarily because of the scope of infection and how little we have left to treat it. Actually, both of these infections, Neisseria gonorrhea as well as Mycoplasma genitalium, have only one recommended treatment here in the US, with very little sort of salvage or alternative therapy. I think the reason why Neisseria gonorrhea is such an urgent threat is we understand so much about it because of national gonococcal isolate surveillance. And we know that about half of gonococcal isolates have antibiotic resistance to at least one class of antibiotics. The reason I think Mycoplasma actually probably belongs on this list as an urgent threat, but we don't do any surveillance on it, and we don't have a great way to culture Mycoplasma. Only a couple of labs in the world do it. It's very difficult and can take up to 6 months. So in terms of trying to determine antibiotic resistance in this particular bug, it's very, very challenging technically. But so it's on the watch list. Doesn't have the status of gonorrhea, but again, 2 STIs, both very common, Mycoplasma being actually even more common than gonorrhea, are things that we need to be concerned about for antibiotic resistance. And so anything like, for example, an MPT that might be able to prevent this infection, would be great as well, from not having this infection circulating in the community and perhaps having an opportunity to develop antibiotic resistance. Next slide. And I just wanted to say, I mentioned that there is very little left to treat gonorrhea. This is a timeline starting from the 30s with sulfa drugs, going all the way through penicillin, fluoroquinolones, and now cephalosporins from 1930 down to 2015. And we do not have anything other than cephalosporins as a recommended treatment for GC, although some drugs are in the pipeline and have gotten into phase 3 trials. There is nothing that is yet ready for prime time that we could recommend at CDC for treatment in the cases of treatment failure. So we are pulling things out based on literature with in vitro data, as well as prior experience from other countries, but do not have a recommended antibiotic class that we can use other than cephalosporins. Next slide. So we are sort of in hot water, as I mentioned, for ceftriaxone, which is the only treatment recommended for gonorrhea. We recently doubled the dose in the last treatment guidelines from 250 to 500. Some countries actually use 1,000 milligrams. Now as I mentioned, there's only one recommended treatment for Mycoplasma, and now patients need to take 2 weeks of therapy, which is doxycycline for a week, twice a day, followed by moxifloxacin once a day for a week. And I'll tell you, patients have a really hard time taking antibiotic therapy for this long. And especially if they were the partner of someone who had Mycoplasma and they test positive and they're asymptomatic, they're reluctant to take antibiotics for 2 weeks. And next slide. So I wanted to also share with you, because this is a project I've been working on with CDC for quite a long time, that CDC now has 2 treatment failure registries. So for those of you who are seeing patients, please report if you do have any suspected treatment failures for the recommended regimens. by CDC, and there is a gonorrhea treatment failure form as well as a mycoplasma treatment failure form. And then again, clinical support is available from CDC, from folks like myself and my colleagues. And so we strongly encourage everyone. They're, on REDCap, which means they're accessible to anyone in the general public. Please report your cases to us so we can get a better understanding of what's going on with treatment failure out in the US. Next slide. And I told you I wasn't going to end on a downer. So, wanting to be product neutral, I'm just mentioning this product because it is pretty far along in terms of potentially being an MPT. But as Bethany mentioned, there are many products in the pipeline. This is a gel that is actually already FDA approved for contraception. It has a combination of different acids. It's called Phexi, and the acidic pH of the product reduces sperm motility. It is prescription only, and its failure rate is pretty similar to diaphragm or spermicide. So that's 13.7% pregnancy rate over 7 cycles. So not an amazing contraceptive, let's just put it that way, but can be used with other, barrier methods, for example, such as condoms. Next slide. And the thing that I'm hopeful about here is that in their phase 2 data for this particular product, there was a risk also of chlamydia and gonorrhea for folks that use the product. I don't know the exact mechanism, but we did see a nice reduction in chlamydia risk, about 50%, and a relative reduction for the risk of GC of 78%. So, this company is fast tracking to get an FDA indication then for STIs as well as for contraception. And that would be very exciting to have another multi-purpose prevention technology that could potentially prevent both. And that could be controlled by the person with a vagina, for example, to prevent both pregnancy and STIs. I told you I wasn't going to end on a downer. Next slide. I just want to acknowledge Patty Kaysen, who provided me with the slides for the intravaginal gel, and just show you, this is my clinic, and this is Phil, a costume, who someone parades around in Phil at events in San Francisco. This is the healthy penis. Just wanted to say goodbye from the healthy penis. Next slide. And thank you for your attention. And these are all the ways to get in touch with me. If you're shy and don't want to ask a question during the Q&A, you're free to email me or DM me on social media.
Ina, thank you so much for such an awesome talk. That was really, really fascinating, and also it was nice to sort of have you end with a hopeful note. So with that, I do want to remind everyone that we will be having a facilitated discussion at the end of this, but if you could hold on to your questions or put them in the chat, we'll be sure and get to them. So with that, I'm going to hand it over to James.
Thank you so much, Bethany. And Ina, I thank you for kind of setting the stage for what I hope to be a little provocative about in terms of development of MPTs for STIs. So for those of you that don't know me, I lead a team within the Prevention Sciences program that's really focused on early development of MPT products. So today we can move to the next slide. Today I'll be talking, well, first I should say that the views I'm expressing today are not necessarily the views of HHS or NIH, but I am happy to provide some views and some perspective today. Next slide. So what I'd like to do is start with just a brief overview of MPTs that are currently in development. Then from there, I'll move on to some real challenges that I think we face and potentially that many groups are very focused on and trying to find ways to resolve those challenges. And then end on a positive note with some opportunities, I think, for the field as a whole, whether it be HIV specific or STI focused MPTs. So next slide. So why maintain an MPT pipeline? I think Ina nicely demonstrated that the statistics just show it. I mean, really, despite the availability of condoms, modern contraceptives, and HIV PrEP, we have licensed products for all of those. The global annual reports continue to indicate nearly 121 million unintended pregnancies per year, 1.5 million new HIV infections, and then really the staggering numbers for sexually transmitted infections, 374 million. So it makes sense, right? I mean, I think the concept for an MPT, a product that would have combined protection against overlapping risk in one product, it would have hopefully simpler use, lower burden, higher acceptability, presumably, and increased public health benefits. But despite that enthusiasm that I think many of us share for such a product, really, if you look at the interest investment over the past 10 years, the condom remains the only approved MPT. And I'll say that again, the condom remains the only approved MPT. So there are candidates and there's quite a pipeline, and I'll actually focus and describe some of that in the next few slides. But we do have some hope. There is a potential product, the dual prevention pill, that's the furthest along in terms of research and development. And I'll highlight some of the positive aspects of that product, which we may be seeing over the next couple of years. Next slide. So I really want to dive into the landscape of MPTs, and I have to say IMPT, their website is fantastic, and Bethany talked about this. So if you want more information, anything around what I'm discussing today, please go to mpts101.org. And so the graphs that I'll be showing come directly from the website, but I've created some tables just to dive in a little bit deeper and to give you some more details to help make some specific points. But if we look at this particular slide, as Bethany said at the beginning, the current landscape is predominantly focused on HIV and pregnancy. And so you'll see the number of products in preclinical development, those in clinical development. And really there's a good reason for this. End user data that started to be acquired in HIV prevention suggested that there could potentially be an increase in uptake of oral PrEP among women in high burden settings that may be as equally or more concerned about pregnancy. So by combining indications, could you presumably increase the uptake of PrEP? And then also the fact that this could potentially mitigate stigma around women who will be seeking HIV prevention services if they're essentially seeking pregnancy services that happen to have HIV prevention in the same product. Maybe you can avoid some of that stigma. So next slide. Looking at products by the stage of development, you can see again, we've mentioned this earlier in the conversation today, the majority of products are either early preclinical or advanced preclinical, so not yet in clinical testing. So there's 17 products at that point. And then we see numerous products that are actively in clinical testing, including some such as the dual prevention pill that are in bioequivalence studies. So again, there's a pipeline, but that pipeline is predominantly focused on HIV and pregnancy, which I'll come back to with some of the data with other non-HIV STIs. Next slide. So if we look at the product delivery type, you'll really see, and I say this in the bullets on the left, that MPTs have really followed in the footsteps of topical microbicides. It makes sense. These products were being developed for HIV. And so as we were focused on products that could potentially add in other potential drugs for another indication such as contraception, it makes sense that these products could potentially also be used for an MPT. So you'll see the range of topical products such as intravaginal gels or intravaginal rings, vaginal gels, fast dissolving inserts, and films. The same type of products appear in the MPT landscape. But we also see products that would be more systemic in their delivery of drugs, such as injectables, tablets, implants, and microarray patches. I think it's important to note, and it's easy to see, that IVRs dominate the landscape. And there's really a good reason for that, as IVRs have been developed over time, and there's many different types. There's matrix IVRs, there's core and sheath that have different drugs in different compartments. And then there's pod-based IVRs that really allow much more flexibility in combining drugs that have very different physiochemical properties. So when you're talking about an MPT that would be delivering multiple drugs, IVRs are very attractive. However, as we know from end user data, and also the fact that that's stated here that we have licensed contraceptive IVRs as well. But however, as we know from the HIV prevention field, women, for products that are geared towards women, not all women want an intravaginal ring. So I think it is important that we consider other product types for development of MPTs. Next slide. I wanted to spend just a little bit of time talking about systemic versus topical delivery. I see some people on the call that have been involved with myself in topical microbicides for quite a number of years. And really, whether you think about systemic versus topical delivery, it's all about getting the right drug in the right amount at the right place at the right time. And so if you look at systemic delivery products, and these would be the pills, the implants, the injectables, the microarray patches, both hormones and HIV antivirals can be effectively delivered systemically. And it makes sense. And you want to make sure that you've got full coverage just in case HIV makes it past the genital barrier. Then when you look on the topical side, you can also deliver hormones and HIV antivirals topically, but this is where you see, at least by looking at MPTs, the broader range focus more on STIs by delivering topical products. And this makes sense, particularly for bacterial pathogens, because their site of infection is within the genital tract. So the types of products that would work well for topical delivery would be IVRs, gels, the fast dissolving inserts, and vaginal films. So I did want to point out, and I'll get into a little bit more detail about the types of products that we're seeing that are focused on STIs, such as chlamydia and gonorrhea, are not specifically antibiotics. And there's a belief that even though it's an attractive target to have that type of a drug, there is that potential concern in a young population that might be using MPTs on a regular basis that this could lead to bacterial resistance, even in a population that's using a product for prevention. So I think that's been one reason that you're seeing these more broad spectrum agents, which I'll describe a little bit more, that have been used against non-HIV STIs. But I did want to make a statement about doxypep. I think the data that came out that was quite exciting about the morning after pill and how effective an antibiotic might be against STI raises some really interesting questions. And so could that potentially provide greater support for use of antibiotics in MPTs? And I don't know the answer to that, but I think it is a somewhat provocative question to be asking. Next slide. So if we look at the pathogen or disease type, again, the common theme that we're hearing, the dominance of products that are, whether it's preclinical or clinical, that are really focused on HIV. We do see some products that have HSV as an indication, and much of that is due to the fact that tenofovir or tenofovir-based regimens are effective against HSV, so that's one reason, but we do have some other antivirals that are specific to HSV, such as acyclovir. But you see this pretty dramatic drop-off as you look at the other non-HIV STIs, gonorrhea, chlamydia, HPV. I do include bacterial vaginosis here because there are products that use that as an indication, even though it's not specifically an STI. Next slide. So if we look at the landscape of drugs that are being used specifically against HIV, really, I think most of you on the call that are familiar with the advancement of non-vaccine based products, we see the same players essentially that are being developed for non-vaccine products, whether it be long-acting products, implants, intravaginal rings, dapivirine, cabotegravir, tenofovir, the various forms of tenofovir. So it makes sense that that would be the types of antivirals that would dominate in the pipeline. But the goal, of course, I allude back to the fact that since adherence was an issue, and thinking that combining with a contraceptive or potentially with an anti-STI drug might increase adherence. That's why you saw this combination approach of taking these products being developed with one indication and then developing another drug or identifying another drug to pair with these HIV drugs for a successful MPT. So next slide. So really, in terms of looking at contraceptives, I have the low-hanging fruit icon here. it made sense for groups in terms of hoping that there would be a shorter regulatory pathway to a licensed product to really think about the progestins and estrogens that were currently licensed and then combining those into a product. So that's one reason why you've seen this dominance of early products that are really focused on combining these HIV drugs with the contraceptives that you see listed here. I mentioned earlier that the most advanced product is the dual prevention pill. And so we have the Population Council product as well as the Viatris product. And so again, thinking about a pathway that would be the shortest to potential licensure, this would actually be combining oral contraceptives with oral PrEP, and that's what I show indicated on the right. And that can either be with an over-encapsulated pill or a layered pill. And you'll see that it's a pretty aggressive approach. You know, if this works, depending on the results of the bioequivalent studies, we could potentially have the next licensed MPT. It does raise some really interesting questions. Will this be the next MPT? So time will tell us. But I think there's also been this thinking that I've been exposed to that this could potentially lay the groundwork for the development and rollout of other MPTs in the research and development pipeline. And I really question that. I would be interested in getting some feedback from some of you on the call, because there are certain, taking the low-hanging fruit approach and the more direct path with licensed drugs with a pill is very different than taking these active drugs and putting them into a film or a gel or an intravaginal ring. And some of the potential barriers with moving forward with those products, it may not be as direct. And so I'm not absolutely convinced that the DPP would pave the way. But don't get me wrong, I think getting to the point of having the licensed MPT is important, but we can't let our guard down that it's going to make it any easier for us to come behind it with other products in the pipeline. Next slide. So this, since the focus of this webinar is really on STIs, I did want to point out that we do have products that contain agents specifically for STIs. But if you look at antivirals, and so if you look, for example, on the table on the left at the top, I mentioned tenofovir has activity against HSV. We do have some products in preclinical development that are using pratelivir or acyclovir. But other than those categories, if you look down the list, everything else is what I'm calling a broad spectrum agent. And so by that, if you look on the right at that particular table with cugrifacin, Yazogel, Vivagel, these are products that are more broad spectrum in the sense that they block the binding and entry of pathogens. And they all have a slightly different mechanism of action, but it's really relatively the same. So the thinking is that if these products prove to be effective clinically, the chances of resistance may be less. And so there's hope in the field that that could be the case. And so this goes back to, I think, some of the excitement that Ina had about potential products with this type of mechanism. And I think it'll bear out to see if these products work clinically. And then the last product, which is the EVO 100 gel, which its mechanism of action is essentially keeping the vaginal pH at an acidic pH, which is hostile to pathogens and their ability to attach and invade. So that's very much where we are in the current landscape in terms of the type of products against STIs. And you'll see on the left that these have some general activity against gonorrhea, chlamydia, HPV, and in some cases, there's an indication for bacterial vaginosis. Next slide. So turning to potential challenges for the field, there are real challenges. I mentioned earlier, physiochemical properties that can be very different. Hormones behave very differently from small chemical entities, from different types of HIV drugs, hydrophobic, hydrophilic, etc. So the challenges of the different physiochemical properties, the potential for drug-drug interactions. You know, we've seen that there are some topical products that have had some interactions with topical fungicides, for example, or antifungals, for example. And so there have to be ways to test these preclinically to ensure that as we combine these drugs, that they remain safe and that we don't have potential drug interactions. The second challenge, I think, for product developers is matching the pharmacokinetic profiles to ensure that you have the optimal release of the drug over time, that you approach steady state, and that they're matched in the sense of dosing and dosing intervals. And also, I think linked to this is the fact that we have to think about the potency of the drug. The less potent the drug, the more drug is required. That impacts the drug load, and this ultimately impacts the size of the product. And so that leads to the next issue, which is the establishment of dosing intervals. And so what is acceptable to an end user? How often will they have to come back? The longer acting products are exciting in the sense that it won't be a daily approach, but weekly, monthly, bi-monthly, up to a year or longer, what makes the most sense and what will our end users accept? And what will the medical community, in terms of support through clinical support and access, what potential impact would that have with the dosing interval? And then you have to think about the science of what's feasible. You may have heard the field talk about, for example, the PK tail. So when you have a long-acting product where the drug slowly decays over time, that has specific implications around at what point is it no longer protective against HIV or an STI? And then at what point does that impact when you have the person come back for their next dose, for example, if it's a longer acting product? So marrying all of this together for early product developers is a real challenge. And it's a challenge for us in the HIV prevention space, and certainly continues to be a challenge in the MPT space. And then finally, I think a common element that we're hearing from some of our earlier product developers is how to establish appropriate in vitro, in vivo release models so that you can better correlate and bridge data into humans. And this is important because in order to expedite the pathway, our developers need to be able to down select to their lead formulations and move those into clinical testing. So better improved models would allow that to happen much faster. Next slide. I did want to mention that in addition to something like just the science of the formulation itself, there's some other real key issues that will impact, particularly advancement into the clinical development of MPTs. And one of those are potential obstacles to manufacturing. Many of our groups that are working with really novel systems, there's the issue of feasibility of scale up to final formulations. And so I think that's something that we have to be thinking about. Mixing hormones and non-hormone drug products. Many contract manufacturing organizations have specific concerns around manufacturing a contraceptive and adding in another drug. And so we do have some developers who've begun some really interesting conversations with these groups about how to achieve that. The design of clinical trials. I think many of you on the call know that as we have approved HIV prevention products, for example, it's going to make it harder and harder to design these studies. And there are important implications on cost and timelines. And then finally, regulatory challenges. What are the requirements for licensure of a combination multi-indication product? What would be required for an IND? What are the types of clinical studies that would be required? And this has a major impact on the novel delivery systems, such as the long-acting products that we have. And then one more slide. So I'd like to end with opportunities for the MPT field. I think there's interest in expanding the availability of options of drugs. There's great interest. I didn't describe it. There are some non-hormonal contraceptives being developed, but given the potential side effects from hormonal contraceptives, there's belief that there might be better user acceptance and safety of using non-hormonal contraceptives. But again, we have to keep in mind drug-drug interactions. More potent antiviral drugs. We have developers that are looking at pro-drug approaches to improve the potency and to improve drug loads of some of their products. Again, I mentioned doxypep. Will that have a potential impact? Could it open the door for MPTs that use antibiotics? I think that's a big question. And then monoclonal antibodies, we do have some products that are actually using monoclonal antibiotics early, or monoclonal antibodies earlier in product development. I think we need to consider all populations at risk. And so there has been a justifiable focus on cisgender women for the development of the early MPTs, but we need to be thinking about cis and transgender men and women as potential candidates for use of this product. Fostering better communication and collaboration between funding agencies. And I can say that that's something that I've been involved in with some of the colleagues that I see on the call at USAID. We believe that I think maintaining sustained support for MPTs is important. Avoiding duplication and ensuring that MPT programs complement each other is another important issue. And then making sure that we leverage and optimize limited resources to address priorities and gaps and advance the most promising of these candidates. And then finally, I'll end with the integration. I think Bethany mentioned this early on. There have been traditional historical silos between preclinical, manufacturing, and regulatory expertise in the areas of HIV, STIs, and contraception. And better integration between the groups that work and specialize on these products, I think will help us be a little bit more successful in figuring out the complex manufacturing that's required, and also in our discussions with the regulatory authorities around what the regulatory pathway and what that should look like for MPTs. So with that, I will end and take any questions.
James, thank you. Wow, you covered so much. And it was such an excellent presentation. Thank you so much. And yeah, I'm sure there's going to be a lot of questions on what you talked about. So I'd like to remind everyone to please add your questions to the chat, and we'll get to them right after we hear from Dr. Kathy Yang. Kathy?
Thank you, Bethany. So I have just a very short presentation on how we can potentially bridge the gap. And I'm really going to focus on what James talked about in terms of the silos and the collaboration. So this is just sort of a recap of what has been taking place with CAMI Health and sort of our attempt to narrow the gap a little bit in terms of collaboration. Next slide, please. So I'm sure everybody has seen some version of the slide when we talk about drug development. There is this valley of death between basic research and compound discovery and getting the drug to market. This is a process that takes about 20 years to get any type of drug from discovery to FDA approval, and it's not unique to MPTs. This is basically true for any drug development. And especially for myself in the area of infectious diseases, this is incredibly problematic. I mean, it takes 20 years to get a drug to market. It costs us $1 billion to $2 billion to get there. It requires intense collaboration between industry and academia and funders. And as you can see, the pitfalls are many. The products can die at basically every step of the way, as you all know. So one of the things that we have tried to think about is how do we make this process a little bit smoother, and how do we minimize this valley of death? So many compounds, as you know, are screened for and are found to have activity against some type of pathogen or has some type of effect against whatever disease you're looking at. But many of these drugs don't get out of this sort of discovery phase, not because the drug may not have scientific merit, but they can die for multiple reasons: funding, feasibility. Just many compounds have been discovered or are known to have activity, but don't sort of get out of that discovery phase. So what can we do to try to make that a little bit smoother? Next slide. And I just want to show you this slide because, as I said, this is not unique to MPTs. This is a slide that I have when I look at antibiotic development. I mean, especially for these drugs that have niche markets where they have very small populations using them relative to disease in general, it takes a long time for these drugs to become profitable. You know, antibiotics is the best example. Invent a bad antibiotic and no one will use it. Invent a really good antibiotic and really no one will use it. You know, that's really true of antibiotic stewardship. But this is also true for any drug that is not widely used. You know, we're not talking about drugs for diabetes or for hypertension or hyperlipidemia. We're talking about a relatively narrow scope relative to disease in general. And these rare diseases are hard to get to the market because the end user population is very small and relative to other diseases. So it's hard to be profitable in that respect. So this is one of the challenges, I think, from a regulatory perspective that FDA has been trying to address, but still needs some work moving forward. Next slide. And this is a slide that both Bethany and James have showed you already. This is the database on the IMPT website that just shows the products that are already in active development in various stages, and the ones that look the most promising. And unfortunately, you can see this, if you try and go to this website, look, there's not that many products. You know, there's a total of about, 28 in total of drugs that are actively in the pipeline. So one of the things that Bethany and I tried to do was look at other products that may be out there, other compounds that may have promise, but are not yet in development. And what we found was the following. Next slide. We actually did a review of different sources to see what other compounds out there had activity against all the different STIs and HIV, and to see where they are in sort of their discovery phases. And we looked at chlamydia, gonorrhea, syphilis, all of the different STIs, as well as HIV, searching through PubMed, NIH Reporter, conference proceedings, clinicaltrials.gov, just to see what was out there and how far each of these compounds got. And so we put together a nice little report that is actually available on the IMPT website. This is a separate report from the one that you saw before, because those are the ones that were in active development. And these are the ones that may have activity, may have promise, and were either in different phases of development from preclinical all the way through clinical trials, but may not have been further enough along to be included in the other database. Next slide. And the way we set this up is we looked at it by pathogen. And within each pathogen, we looked at the compound. We included some basic pharmacological activity or classifications. We looked at whether or not there was even any data on route of administration or formulation. And we also included who was the lead resource or researcher on that, that compound and the PubMed source or the conference proceeding. And what we did was we tried to be as inclusive as possible, but realizing that this was basically an unknown. There is no denominator for how many compounds are actually being developed for each of these STIs, because we just don't know. I mean, you could look forever and find many, many compounds that have activity, yet not being moved forward. So we did our best to be as inclusive as possible. But what we also found was this review led us to the understanding that we actually do need some type of open source database or some type of way to catalog what other researchers are doing as a way for us to connect each other in the field. And this is looking at compounds, but we could easily say, oh, we need the same thing when we're talking about drug delivery systems. Because for an MPT to be successful, we're going to need to put the two together. Next slide. So thinking ahead, one of the goals that we want to do is to actually create some type of open source library of promising compounds or drug delivery systems. And The goal, of course, would be to enable research labs and public health groups and other stakeholders to collaborate and network, sort of a mix and match. I'm working on this, you're working on this, could we put them together? And there's a lot of precedence for these open source libraries. I think COVID was the perfect example. You know, when people were doing genomic data, people were throwing out all the data on the individual variants into these public libraries for people to search. And of course, we have in the field of drug discovery, there's lots of compound libraries where people have included the compounds they have found and what their activity is against whatever pathogen they're looking at, or cancer cells, whatever. So looking ahead, this is something that we would see as a goal. Could we do something similar where we have an open source library where researchers start including their findings of what worked and what didn't, which would allow other researchers to network and find partners in order to collaborate. And so the rest of this discussion then, when I'm going to turn it over to Bethany, would be then to ask you guys, what other tools do we really need to bridge this gap? What can we do to make it easier for researchers to connect, to network, and to sort of minimize these silos? Bethany, I'll turn it back to you.
Gosh, thanks so much, Kathy. That was excellent. I just want to say thank you to Ina, James, and Kathy for just your awesome collaboration and work in putting together these slides and this presentation today. We're now going to open it up for questions. We'd like to have you all submit your questions into the chat. If you have a question and you'd like to ask it yourself, that's great. We really want to create, the purpose of this virtual forum is to create sort of this virtual community. And I think so many of us here that I'm seeing have joined already know each other. So we'll do our best to follow the chat and let people speak. And we will unmute you for questions. And when you do, ask a question, if you could just state your name and affiliation. So as we're collecting those, as Kathy said, we do have a question we'd love for you all to sort of think about and even just put into the chat for us to start thinking about. And that is, from your boots on the ground experience in this field and in the broader sexual reproductive health field, product development, what do you see as the biggest challenges for advancing MPTs and tools that could be needed and used to help advance the field? So so if people have thoughts on that, and maybe even if any of our James or Ina or Kathy want to reflect on that too, that'd be great. Well, we can think about that some more too. And as you're thinking about that, I'd like to actually move over to James for a question, sort of building on some of the comments that you raised or points you raised. And that is, what is the prospect for MPTs having activity against STIs that are bacterial, like gonorrhea? What do you think the prospects are of that?
So I think in looking at Katherine's presentation, and this is just off the top of my head, I mentioned this earlier before the webinar, that funders have constraints around how we put out announcements, for example, with NIH and the types of products that we would be developing versus other groups. And so we can put the characteristics for what we'd like to see. We can say what we would not like to see and to kind of push the field forward. But drug selection, in my mind, has been a really tricky thing because, as I mentioned in my talk, we pick the low-hanging fruit. We pick what's already licensed, whether it be a contraceptive or an HIV drug. Having access to newer compounds and newer drugs as something that could potentially be exciting for MPT development. Now, there's the caveat that what does that regulatory pathway look like, right? Because you're thinking that licensed drugs are going to make it easier, and I don't know if that makes it easier, as I said in my presentation. But I like the idea of a database or somehow bringing, especially in the STI space outside HIV, a group together to really think about, are there drugs, antibiotics or otherwise, that could be considered for MPTs?
Thank you, James. Kathy, do you have more to add to that?
No, I was just thinking of the comments about the repurposed drugs. I love the idea of attempting repurposed drugs. It's the low-hanging fruit, of course. And there is precedence for other disease states to use repurposed drugs. I always mention that Viagra is the perfect example. Viagra is the most successful repurposed drug out there, right? It's difficult, and you do cut out a lot of the pathway in terms of the regulatory requirements. You cut out a lot of the discovery, but then the clinical trial part, the regulatory part at the end becomes cumbersome and burdensome. So it's a little bit of a catch-22. I never want to discount it as an opportunity, because we just have to take whatever opportunities we have. So I think it's still a feasible way to go. In the area of infectious diseases, it's not always been the most promising. COVID, I think, was a great example. None of the repurposed drugs for COVID seem to work, but that doesn't mean we won't find something that won't work in the future.
I know, yeah.
Can I just ask a quick question about that? Because my understanding is that even if you were going to be using a product that was already licensed, if you were delivering it with a different vehicle or delivering it vaginally or something versus orally, that you would still need to go through a very rigorous testing process, right? I mean, and just to add to what I see as a huge barrier, I've just been giving advice to this company that's trying to reissue the internal condom and making it sort of sleeker and smaller and, toying a little bit, same source material as what's already approved, but just because the shape is changing and the size is changing, like they still have to go through a very arduous regulatory process. And so I just had my eyes opened to how truly difficult that is. And so you cut some corners by using a product that already exists, but it sounds like because if you try to deliver it in a new way, you can't get around certain requirements. Is that correct, folks?
I mean, if you do an oral contraceptive and then you move it to the patch, that goes through an entire new regulatory pathway, right? Or if you have an injection to like fentanyl injection to a patch, that goes through an entire different process again. It's totally true. It does start over. So there's a regulatory process for the drug, and then there's one for the delivery system.
Yeah, and I think that there's a bigger overarching issue, which I think it was Lisa Haddad who mentioned it, was, well, what kind of funding federally is there for non-HIV STI prevention? Because that plays into all of this, right? And I really feel like there was a very small increase in appropriations for non-HIV STI, and not enough to do anything, even bring one product to market or to support that even. I feel like it was $10 million or something like that, so I think that is a big factor, is that the money issue is huge here.
Yeah, and that actually, thank you, you guys. Lisa, thank you so much for that question. And it actually really aligns with another question that we got, pre-form question for this webinar. And, I was going to sort of post this to James to kick it off. And that is that, given that many funders in the MPT space have diverse mandates and, the funding is limited, what do you think as a funder yourself are ways and strategies to best advance the field and fill these gaps and address these challenges that are many that you covered in your talk?
So I think the easiest answer is more frequent and regular discussions, to be honest. I did mention that we've started some discussions with our colleagues that are part of the Matrix program. And to be very transparent, you know, I have a grantee who is developing what appears to be a very promising MPT injectable, but their funding will run out within the next couple of years. And so unless I have a funding opportunity announcement ready to go, but yet it's NIH, the grantee has to go through the review process. And so I can't guarantee that that person's application will be successful and we can fund them. However, the Matrix program is in a position to potentially consider and support that product. So I think that communication between the funders, do we agree that it's a highly prioritized product? Is there a way that the other groups, you know, NIH can only take certain products to a certain point? If there's a funding gap, can we work with our partners if we agree that it's a high priority product to pick up funding if they can? And then on our side, can we continue to work to be thinking to the future? And do we get support from leadership for future initiatives to continue that support?
Yeah, and I think I'll just add to that a bit too. And, you know, with the, you know, how do you engage and incentivize other types of investors, private sector investors, CRO, impact investors, and others, you know, who might be looking for the ROI? And, you know, there are opportunities, you know, within NIH, there are non-dilutive funding mechanisms that can help support sort of the business end of things like that and provide coaching. And I know Matrix also has a hub that's trying to sort of look at some of that too. So thank you very much. I see that you know, there's some other questions. I'll hand it over to Kathy. Do you have some questions that you think would be good to ask the group?
We had the one question, I think, that I think James alluded to also in terms of regulatory requirements for other populations, LGBTQ populations. Do you remember that one? Do you want to read that one out loud?
Oh, sure.
I think that was a really good question to ask.
Yeah, so what I think this one was, what are the R&D considerations for the LGBTQ populations? And we were thinking if that's the one that you were talking about, Kathy, you know, I think we talked and sort of brought this up with both Ina and James to maybe help address this.
So I think from my perspective at NIH, there are some constraints around how we put out our funding opportunities. And so we do want to be as inclusive as possible. And so, but we don't necessarily we aren't prescriptive about what is that product going to look like for a gay man or a transgender woman. So in our announcements, we leave that open to the actual investigators, and you know, through partnerships with our other institutes such as NIMH, there's typically language about incorporation of end user characteristics through studies with these populations to feed back to the types of products that would be developed. So, you know, from my perspective, there's constraints. We have to put out an announcement with the type of characteristics and hope that we get the applications that make it through review that we could support through that mechanism. So I leave it to my if there's any other funders on the call who have, you know, a little bit more direct oversight of product development, they may have some ideas for addressing key populations.
Yeah, and I do see that James made a great, Jim Pickett made a really good point that, you know, this is it's a broad population. And I don't know, Jim, if you wanted to I know you've been thinking a lot about this too. So if you wanted to comment any further.
Sure, I would. Thanks. And thanks for calling me Jim. I don't know why my thing showed up as James. I'm nothing against the word James, but I'm definitely a Jim. I just, I've been working in the space for a long time. I'm a huge fan and supporter of MPTs for people who can get pregnant, and it makes sense that most of the options right now are things that attach HIV prevention with pregnancy prevention. But we need to do so much more for other populations. I appreciated that James had a bullet on his slides talking about the needs of gay men and transgender folks. But we need more than a bullet, right? We need actual research and work on this. And there's something that wasn't mentioned in the talks, but has been work going on for several years around a rectal douche that Craig Hendricks and his team at Hopkins have been working on. And hopefully the HPTN will take that to a phase 2. Hopefully we'll find that out soon. And I just also wanted to note that while there are these huge populations with very different needs, and we can't kind of say the LGBTQ community needs to be involved. Well, that's lots of different people. So we need to resource that appropriately. I just also want my last point I put in the chat and just highlight something that I think our field often forgets, is that anal sex is a human behavior. And we need to provide things that protect folks during anal sex for all humans. It's not just the purview of gay men or transgender individuals. So there's some places where we can overlap and think about the needs for humans. Well, most humans have butts, and a lot of them have sex using that orifice. So I think there's a lot of potential there that we're not really exploring for lots of reasons. But I could go on and on and on. So I will pause my comments there, other than to just say, I think one of the issues we have and one of the barriers we have with maybe moving some of these forward is our love affair with efficacy and effectiveness, as if that's the only product attribute that matters to people, and that's the only thing that will get people to take those products up. The best product is something that people will use, and we know from contraception that many people use products that are not the most effective, but it's the one that works for them in all kinds of different ways. I'm really concerned that our field in the HIV prevention space is completely dedicated to only things now better than cabotegravir long acting, right? So things that are even longer acting and even, quote, more efficacious. I think that's the wrong way for us to be going. Thank you.
Ina, yeah.
Bethany, can I just comment, because Jim, you had so many comments that sort of sparked me, the hamster started running around in my brain really fast. And I think contraception does a good job. I'm just using my clinician hat because I take care of patients, and the contraceptive field has done a good job with this, in the sense that, yes, you can have a contraceptive that acts for 5 years. You can have a single-use product, and they have everything in between. If you want to use a vaginal product, if you want to use an oral product. And I agree. I mean, like right now, our clinic is like laser focused on like implementing cabotegravir, and like that actually doesn't work for some people because they don't want to put a product in their body and then have it sit there for months. And if they have side effects, then they're sort of stuck with that. So I think that we need to think about STI and HIV prevention in the same way. We're saying there's different products for every season in your life and every type of person who might want to use it. And I think where the internal condom made that huge mistake is it was marketed as like, for regulatory reasons, as a female product, and the labeling and packaging and what it's called. And obviously, men might not run to a product for anal sex that says female on it. So I think having people at the table when these decisions are being made who are members of the community to say, wait a minute, we could use it for this indication, for people to think about that from the get-go, because otherwise you end up with people, and I say this all the time, I have data in cis hetero people because that's all there is. And then, we end up in the situation where people in the community don't trust us because they have no idea if what we're saying actually even applies to them. So, I just think it's not going to happen overnight, but I see it happening with advocacy from community members saying, no, it's not good enough to only include cis men in this study, and it's going onward from there. But things still happen, like we just mentioned with Descovy, where there's no data in women at all, cis women at all. So we have more work to do. Okay, so
That's great. So, any more questions around that? I do see that, we have a couple more questions in the chat. I'm just trying to sort of look at these as they're coming in. I see that Burko Uner, you posed a question, and I wanted to see if you wanted to elaborate on that. It was directed to James and Ina, I think.
I'm sorry, Bethany, I was scanning the chat. What you were saying, there's a question directed to us?
I think he was, yeah, so.
Yeah, this is my question actually.
Okay, thank you. Sorry to put you on the spot.
Yeah, thanks for having me. I just want to ask their advice, relevance to possibly taking action points toward the table, which is the presentation studies related with the preclinical and clinical studies regarding with the disease HIV, gonorrhea, and of course chlamydia side. Dr. Park also mentioned before in her presentation, and I realized one highly crucial point, which is gonorrhea and chlamydia sites. Working groups have focused on HIV and other viral diseases instead of these diseases. As so incoming advantage in presence of some overlooking situation. So according to these missing points and tackling more effectively with the gonorrhea and chlamydia, could you share your reliable opinions for sake of being more focused and anticipated?
And then may I just ask a quick question of James before he takes a stab at it, and then I'll take a stab at it as well, was I'm just wondering if part of the reason why the focus has been on viral diseases is not only because of how common they are, but because for some of the MPTs you showed, there were already existing and approved drugs, whereas certainly you could use doxy, for example, in a product to prevent chlamydia, but it's never been delivered, for example, in a rectal or vaginal vehicle before. Do you know what I mean?
Yeah, I totally understand. Maybe fixing kind of disease, which is gonorrhea, chlamydia, without using some active substance, maybe we can go forward kind of this way. That's why I want to ask that kind of question. You're also willing about the groups which is using without active substance like lactic acid, other kind of acids varieties. Yeah, I just want to ask.
So I'm going to ask John Glock, if you're out there. I think I see you listed. He is a colleague in the Division of Microbiology and Infectious Diseases, and I think he's probably better suited to answer questions about the STI side of things. So John, are you comfortable answering or giving some feedback?
Hi, yeah, well, I'll take a stab at it. Which specific questions did you have? I'm sorry, I didn't catch it.
Was asking about, like there's a lot of focus on MPTs for viral non-HIV STIs as well as HIV. But then, and then I was just saying, well, things like doxycycline, I'm just taking an antibiotic, pulling it out of the air to say, well, we could look at doxycycline as an MPT for chlamydia, but I don't think it's been delivered rectally or vaginally, so it would need to go through a huge process. And then
Yes,
Versu was asking about products like lactic acid, which don't actually have an anti-infective in them. Do you know what I mean? But the active ingredient is something like that isn't an actual drug.
an active incipient.
Well, inactive ingredients such as like lactic acid or something in some of these gels that are acidified.
Like actual molecule, yeah.
Okay, and yeah, there are several products out there that are in the pipeline now that are using lactic acid and other pH modifiers. I'm still not understanding what your question is. You're saying why they're not being used for viral approach or
for bacteria, for other, why is there not more of a focus on bacterial STIs with those?
Bacterial STI.
Good question. I would say the idea has never come across PI's minds. I mean, I would highly recommend you taking a shot at it. But as far as these, there are some out there that are using these active pharmaceutical ingredients to address bacterial vaginosis by pH adjustment. So, I mean, they're out there. Why there isn't more of them? I would say that just not enough folks have come up with the idea.
Thanks for your
I have a question
high
with
level advice. Thanks.
How
This is
likely do you think it
perfect
is to
answer.
find, how likely do you think it would be to find a MPT product against bacterial STIs that's not antibiotic related?
How likely?
Yeah, I guess, I mean,
Well, there are those out there now. The use of antibiotics, from what I've seen in my portfolio with DoxyPrep, oral delivery is, you know, the DoxyPrep study is the first I've really heard of it. Which isn't really true. I've seen other attempts, but as you know, as delivery in the vaginal compartment, yeah, there's some of it out there, but you know, it's just sometimes there are issues where resistance is the biggest driver that they're worried about. Resistance at the local level, resistance at the systemic level, and that has often been, for lack of a to steal James's one-liner there. This is my opinion, not that of DMID or NIAID or the NIH. I think that this has basically had a chilling effect on the use of antibiotics in this fashion, because to test and check the profile of the resistance profile of every organism that you're going after as an indication is quite an undertaking. It's doable, but it's a lot of work, and it's basically, I think, just kind of throwing a wet blanket on the idea in general.
John, thank you so much for
sorry for not chiming in earlier. I didn't want to steal the thunder of these folks. I'm sorry.
Oh no, yeah, no, that's really great. And I'm just seeing that, you know, we have more comments in the chat. Meredith Clark, excellent comment and suggestion. Would love to follow up with you on that network. Charles, thank you for raising you know, awareness around the galactic cap product. We are now at the end of our time, and I just want to thank everyone again, the speakers, James, Ina, Catherine, for your outstanding presentations and generosity with your time. We will be posting the recording of this, as we do with the others, on the website in the Learning Events Hub. Also, you know, wanted to again point out that this is a website that's open to the public. We really welcome other documents and materials that you all have that we can share. So with that, thank you all again, and I hope you have a great rest of your week and your day. Okay, bye-bye.